Next paper is entitled Preoperative Very Short-Term High-Dose Erythropoietin Administration Diminishes Blood Transfusion Rate in Off-Pump Coronary Artery Bypass, a randomized, blind, controlled study. The author is Dr. Luca Weltert from the European Hospital in Rome.
Chairman, dear colleagues, first of all, I would like to thank the Association for the privilege of this podium. As we all know, blood availability is an essential prerequisite for cardiac surgery. Nonetheless, blood transfusions are not free. They carry both risks and costs. Risks in terms of adverse reactions and the transmission of infectious diseases, and costs in terms of consumption of a life-saving social resource, and of course of money needed for the blood treatment, which is around $300 per unit in Italy. More specifically, in isolated coronary artery bypass graft, as the Cleveland Clinic group showed us back in 2006, transfusion of allergenic blood has shown to be related to an increased risk for postoperative atrial fibrillation, to a worse health-related life quality after cardiac surgery, and even to reduce long-term survival. High-dose erythropoietin is one strategy that has been used many times in literature to obtain a rapid increase in red blood cell count some days before surgery. The shortest preoperative administration interval up to now was 4 days. Unfortunately, in our everyday routine, only 2.4 days separate admission and surgery. So we planned a prospective randomized trial to test the efficacy of a high dose of erythropoietin administered in an extremely short term, just 2 days before surgery. Following the CONSORT flow chart, we assessed for eligibility 400 consecutive patients between October 2007 and September 2008. During the enrollment process, we excluded 80 patients. 60 were not meeting the inclusion criteria, 11 refused to participate, 9 for other reasons. Our exclusion criteria was baseline hemoglobin higher than 14.5 gram per deciliter, a severe renal impairment as defined by the Euroscore model, and the plan to go for on-pump revascularization. We ended up with 320 patients that were randomized either to erythropoietin or no treatment. The allocation process split the population in a group of 158 patients that went to intervention and one group of 162 patients that went to control group. All the patients received the allocated intervention and went on to follow-up. We had no loss to follow-up. The follow-up ended with discharge from our institution. We had 2 patients in the erythropoietin group and 1 patient in the control group that discontinued intervention because they were converted to on-pump revascularization. These were the doses of the protocol: 14,000 units on day -2, 14,000 units on day -1, then 8,000 units the day of surgery, and again 8,000 units on day 1 and 2 after surgery, which means for the average weight patient around 600 units per kg per week. Hemoglobin values were collected preoperatively and on postoperative day 1 and 4, while adverse events, blood loss and blood transfusion rate were recorded at time of discharge. Our primary endpoint was the assessment of the risk of exposure to allogenic blood transfusion, while secondary endpoints were the hemoglobin levels at day 4, as well as the cost effectiveness of this protocol. The randomization protocol, the process worked quite well in controlling the known confounding factors. As you see from the column of the p-values, there was no difference between the two populations in terms of traditional risk factors. There was as well no difference for the variables included in the Euroscore model, nor in the logistic value of the Euroscore risk model. The two populations did not differ in terms of age, weight, baseline hemoglobin, and as well the blood loss was more or less the same. Coming to results, for our primary endpoint, the treatment group required 0.33 units of blood per patient, while the control group required 0.76, and this difference proved to be extremely significant. Expressed in terms of risk, the risk of the treated population was 16.10%, and the risk of exposure to blood transfusion of the control group was 37.10%. Again, this difference proved to be very significant, with a risk ratio of 0.43. In other words, this protocol roughly halves the risk of exposure to blood transfusion. As for our secondary endpoints, hemoglobin level at day 4 in the treated population was 10.79 gram per deciliter, while it was 9.26 in the control group, a difference of 15.5%. And this difference proved to be significant even if at an inferior level of strength. As for cost effectiveness, the protocol actually cost in Italy 243 euros, while we keep paying 270 euros for one blood unit asked for in election and 390 euros for one blood unit asked for in emergency condition. So the protocol saves one blood unit every 2 patients, which means does not meet cost effectiveness actually, but gives an increased cost per patient of 108 euros. So to sum up, administration of a high dose of human recombinant erythropoietin at a very short term, just 2 days before surgery, is strongly related to a reduced need for blood transfusion and to a higher hemoglobin value 4 days after surgery. Thank you.
The discussion will be opened by Dr. Colleen.
Thank you very much. You present intriguing data demonstrating reduced red cell transfusion in patients receiving very short-term use of erythropoietin. I have 3 questions for you, and they pertain to the timing of administration, adverse events, and cost. And I'll allow you to answer in between each one of these. The first, with regard to timing, one of the biggest hurdles for use of erythropoietin in the cardiac surgical setting is the short time interval between when a patient is evaluated and the eventual operation. You demonstrated feasibility and effectiveness for reducing red cell transfusion, as well as increasing day 4 hemoglobin. My question for you is, what were your indications for transfusion in this study? Meaning, was there a transfusion policy such that patients who were in your control group and your erythropoietin group, was there a hemoglobin trigger that you set before a patient would be allowed to receive a red cell unit?
I can answer now?
Yes.
Yes, of course we have a policy of transfusion. We transfuse when the patient hemoglobin falls below 8 gram per deciliter in absence of symptoms, and when blood oxygenation as estimated by saturation of venous blood falls under 50%, even with optimal hemoglobin values. And of course this policy did not differ between the 2 groups.
Wonderful. Now my second question pertains to adverse events. And one of the major concerns with the use of erythropoietin in a cardiac